Good morning, good afternoon, good evening. Welcome to the third TRACE Best Practice webinar. My name is Suzue Saito. I am the Director of Strategic Information at ICAP at Columbia University. And welcome. And today we will be featuring preliminary results from the time motion assessments conducted to measure added time spent on recent infection surveillance activities in Eswatini and in Rwanda. We are joined by three speakers. We have Kylie Flynn, who's a PhD student at Johns Hopkins University, pursuing a degree in doctoral degree in epidemiology, and was formerly the study coordinator for the time motion assessments. And Ms. Lenhle Dube, who is a public health specialist, currently working for the HIV control program in Eswatini as a national HIV testing coordinator. Lenhle holds a master's in public health from Tashira American University and has been working in the public health space for the past 15 years with vast experience in HIV program and monitoring. And finally, we're joined by Dr. Basil Ikuzo, working within the Rwanda Biomedical Center as the director of the HIV prevention program. He holds a Bachelor of Medicine and Surgery from the University of Rwanda and has been with RBC for close to a decade, ensuring optimal levels of regulatory compliance and patient service and support. So we'll first start with a presentation of results from the three speakers, and we'll come together at the end for some discussion and Q&A time. Feel free to use the Q&A function at the bottom of the screen to put your comments in or questions in. You can also use the chat function if that's easier. And we'll try to answer live, and then if not, we'll come together and answer those questions. So without further ado, I welcome Kylie to start us off on today's presentation entitled HIV Recent Infection Surveillance Time Motion Assessments in Eswatini and in Rwanda. Over to you, Kylie.
Thank you, Suzue, and welcome everyone on behalf of the ICAP assessment team. Again, my name is Kylie Flynn, and I will be starting our presentation today, HIV-1 Recent Infection Surveillance Time Motion Assessments in Eswatini and Rwanda. So to start today's presentation, we'll first review the rationale for the time motion assessment and discuss the aim and objectives of the assessment, as well as the methodology used. And then you'll hear from our country presenters some time motion results from both Eswatini and Rwanda. And then we'll discuss some of the limitations and strengths of the assessment, and finally, our conclusion. So HIV recent infection surveillance is established across 26 PEPFAR-supported countries. And ICAP has supported recency surveillance in 16 countries, including Rwanda beginning in 2018 and in Eswatini beginning in 2019. There are some concerns about the cost and implementation complexity of using HIV-1 Asante rapid recency assays in routine HIV testing services in settings where the burden workload of healthcare providers remains high. And to our knowledge, there has been one study published in 2019 that found 68% of healthcare workers reported spending at least 20 minutes per client on RTRI testing in Malawi. So using time motion methodology, we measured the additional time spent by healthcare providers implementing recent infection surveillance to help inform the global guidance on efficient implementation models to scale and sustain recent infection surveillance. So the aim of the assessment was to estimate the additional time spent on facility-based and laboratory-based HIV-1 rapid test for recent infection as part of recent infection surveillance by healthcare providers for each new HIV positive patient in 2 ICAP supported countries, Eswatini and Rwanda. And the objectives were to characterize and describe how healthcare providers organize and structure their time to conduct recent infection surveillance activities, and to assess the differences in time spent associated with point-of-care recent infection surveillance models in Eswatini compared with laboratory-based and hybrid recent infection surveillance models in Rwanda. We'd like to review some of the terminology that you'll hear throughout the presentation. A recency testing observation refers to samples undergoing an RTRI test. Recent result observation refers to those samples testing RTRI recent. Long-term result observation refers to samples testing RTRI long-term. A control observation is one where clients do not undergo recent infection surveillance and only complete HIV testing service and case surveillance activities. A point-of-care facility is one where RTRI testing is run on site, and a non-point-of-care facility is one where RTRI samples are sent to either the district hospital or the hub lab for processing. So for the assessment, we had trained data collectors who used time motion methodology to observe healthcare provider workflows among newly diagnosed HIV positive patients and recorded time spent on recent infection surveillance activities, those that are not conducted in parallel with routine activities at the selected laboratories and facilities over a 3-month period. So in Eswatini, recent infection surveillance is implemented using an opt-out approach, and key messages are integrated within group pre-test information sessions. RTRI is run in parallel with the verification HIV diagnostic test, and a recent infection-specific questionnaire is administered at the facility level. And RTRI recent samples are sent to the molecular lab for viral load testing, and results are not returned to patients. In Rwanda, recent infection surveillance is implemented in HIV testing services as part of HIV case surveillance, and consent for recency testing is part of case surveillance. For those who consent to case surveillance, an additional blood draw is done for RTRI at the facility or at the lab, and recency testing is run in parallel with baseline labs. In Rwanda, results are returned to clients in accordance with local guidelines. A total of 6 facilities were selected in each country based on criteria using case surveillance and recent infection surveillance data from August 2021 to August 2022. These sites were selected for having a high volume of newly diagnosed HIV positive clients, high RTRI testing volume, and number of RTRI recent cases. And we sampled a mix of point-of-care and non-point-of-care facilities in Rwanda and achieved coverage across all 4 regions in Eswatini. And we chose a convenient sample, of 70 recency testing observations or 5 RTRI recent observations in each country. And 3 to 4 control observations were used to provide a baseline amount of time spent on routine HTS in Eswatini and on case surveillance activities in Rwanda for HIV positive patients not undergoing recent infection surveillance. So for our data analysis, the duration of each activity was calculated as the difference between the start and end times accounting for any wait times or pauses. Consent time was excluded because Eswatini uses an opt-out approach and includes key messages within group pre-testing information sessions. And in Rwanda, consent for recency is part of routine case surveillance. RTRI processing time was excluded because healthcare providers typically perform other routine activities while waiting for the RTRI result. And sample transportation time was excluded because recency samples are mostly integrated with the transportation of other routine samples. And finally, machine processing time was excluded from the calculated time. For example, viral load processing time, because recency samples are run with other viral load samples. And we summarized the data by the mean, minimum, maximum, median, and interquartile range values, and stratified by recent infection status and implementation model. We were able to conduct a qualitative review of comments, which helped to interpret outliers and inform our analysis. So this slide describes the observed workflow in Eswatini that includes a total of 6 steps. 3 are routine HIV testing services activities indicated by the black boxes, and 3 are recency-specific activities indicated by the red boxes. And as you can see, recency activities are embedded within the routine workflow, and the yellow triangles signify the activities that are specific for RTRI recent samples only. Similarly, for Rwanda, here are 2 of the observed workflows. The top workflow is for the point of care facilities, and there are 6 total steps. 3 are routine and 3 are recency specific. And for the non-point of care workflow on the bottom, there are a total of 7 steps. 3 are routine and 4 are recency specific. And the country presentations will provide more detail to explain the activities we measured as part of each of these steps. So now I'll hand the presentation over to Lenley to provide some of the results from the time motion assessment in Eswatini.
Thank you so much, Kyle, and thank you, Suzue. I'll be taking you through a closer look to Eswatini time motion results. My name is mentioned. I'm Lenhle Dube from the Ministry of Health, the HTS National Coordinator. I will start by highlighting the assessment procedure. In Eswatini, we observed and timed 2 workflow patterns to reflect the activities that occurred at point of care facilities and also at the control observations. In the point of care facilities, RTRI was run on site and sent samples to molecular lab for viral load testing. And within the control observations, that is when the clients were opting out of recents and following only the routine HTS procedures. Steps measured across the different types of facilities, they varied, as you will see as I continue. The data collectors were based at the health facilities and laboratories, and they communicated through WhatsApp to inform each other about the samples that are being transported, so that they are able to time accordingly. Here, as highlighted by Kyle previously in her presentation, Eswatini workflow for recency is highlighted here. A client will first hear key messages, as you can see here in the beginning, on recency in the group pre-test information session. That includes the information around HIV diagnostic testing while the clients are still waiting in the waiting room for other services. And then The RTII itself is then run in parallel with the second serology test using the sample taken using the same finger prick for those who are positive on the first test. So here, as you can see, then the client will complete a recency-specific questionnaire with the healthcare provider, as you can see the box in red. And then those who are positive on the second test will have to queue for a sample collection and then undergo sample collection for baseline labs, for treatment, and for ART initiation. The same remaining blood sample from the baseline are then utilized to allocate and run the viral load testing, and for viral load testing on those who test RTII recent, as you can see. And then these are the times that have been observed in the red boxes. We can continue. So with this one, these are the steps that were measured by the observation type. These are the sub-activities that further break down the steps that were highlighted in my previous slide in the flow chart. The viral load testing for recent samples noted before includes these 7 sub-activities that are listed in this box. You can see here we have an activity of receiving in the LIS, and then also viral load receiving in the preparation room. And then also centrifugation if there is a whole blood, and also there was allocating if there is whole blood of the sample. And then samples were also fed to the analyzer, and viral load sample analysis was also conducted and timed, and then authorization of the viral load results. And then this on the other side is the control observation, where basically is the pre-test, pre and post-test counseling happening, and then moving to the collection of the baselines. So here it is a snapshot of the assessment that is highlighting the training and site activation that they were conducted in the period of January 2024. And 10 data collectors were trained, and 6 of those that were trained were assigned to the health facilities, and then 4 assigned to the laboratories. And then data collection was happened in the period of January 2024 to April 2024. A total of 76 recency testing observations were completed. 5 of them were RTII recent, and 68 were RTRI long-term, and we had a total of 3 controls. So here, if you can look closely, these are the characteristics of the time observation, and you can see, as mentioned earlier, we had a total of 76 observations. And the majority of these observations, they originated at the OPD testing point, and all 4 regions in Eswatini were represented among recency testing observations. So here in Manzini, we had 2 controls that were there, and 17 RTII long-term. And then for RTII recent, we had only 3, which if you look at all the observations, there were 22/76, which then account to 29%. In the Hoho region, there were no controls, but we had RTII long-term, which were 35, and 2 RTII recent, which accounted to 49%. And then in Lubombo, there were no controls there. And then the RTII long-term in Lubombo were 4, and then we had no RTIR recent, which was about 5%. And in Shisolweni, there was 1 control observation there. And then RTII long-term, we had 12, and then there was no RTII recent, which accounted to 17% of the observations. As mentioned earlier, that majority of the observations originated in the OPD. Most of the controls that we had, they came from the OPD, and RTII long-term, we had 61 from OPD, and then 5 RTII recent were from OPD. Where if you look at the OPD setting, we had 69/76, which is 91%. And then the ANC and VCT, if you look at them, the RTII long-term for the ANC, we had 4, and then we had 3 for VCT, and we had no RTII recent. And then in total, that gave us a total of the 76 observations that occurred. So with this slide, we're looking at the added time of recency activities that happened in Eswatini. So here we show the results of the assessment. On average, recency testing activities added a total of 16 minutes for recent sample and 10 minutes for long-term sample, as you can see, the recent and the long-term. The 16 minutes for recent samples include recency questionnaire time, which the one that you can see in light green, I think, which added 10 minutes, 25 seconds, and then also allocating viral load sample, adding 1 minute and 36 seconds. And viral load testing added 4 minutes and 25 seconds. And then for the long-term samples, there were about 7% of the new positives. And then samples undergoing RTI test, or of course, it was just a small portion, which is just the 7%. So the 16 minutes that was at the time totaled to about 21% additional time, accounting for about 1 hour of client spent on HTS and linkages to treatment activities for recent samples. And 15% was added time for the long-term samples. So basically, this is what the slide is highlighting, and we can proceed. So these are the key takeaways that we have for Eswatini. One key takeaway is that recency is well integrated into routine HTS in Eswatini, with activities often happening in parallel, just like I've highlighted earlier when we are conducting our RDT. And then the average time added for recency surveillance ranged from 10 minutes for long-term results observations to 16 minutes for the recent results observations. And then there was time added by healthcare providers due to recency, which was mostly due to the recency specific questionnaire that was administered during the counseling. Eswatini is also considering implementing case surveillance and baseline viral load testing, which we are looking forward that it will further reduce the added burden for recency. So I guess this was my last slide. I will then hand over to Dr. Basil to continue with the presentation. Thank you.
Thank you so much, Dube, for giving me the floor. So I'm Dr. Basil from Rwanda, and I'm going to take you through our result from the time motion assessment, and I have some of you slides to share with you. Next. Our assessment procedure in our country, we observed in time 3 work flow pattern. We have the point of care facility, which is located in Kigali City. On that point of care is where the RTI test is run on site. And also when we found that the RTI is recent, the sample is sent to hub for viral load testing. We had also the non-point of care facility, which was located in Eastern Province. But the difference with the POC is that for the non-POC, the process of RTI testing are not processed at on site. We took the sample and we sent the sample on the DH or the hub for the RTI test, but also for the viral load when it come recent. We observed also the control. The control was the routine activity without including the recent testing. So we have we measure different step across our different type of health facilities that we have. So in the assessment too, also what I can highlight is about that we have tried to measure the time we use on sample transportation by using the communication on WhatsApp between the data collectors and the staff will be receiving the result at the hub or at the district hospital. Next. So this slide, I want also to try to go in details of what have been mentioned by Kylie. So in our implementation workflow, we have two different type of health facilities where we have POC and non-POC site for recent testing. So as shown here, the first one is the point of care facilities. First of all, when we took the test, we do the counseling, the post-counseling test for the one who's becoming HIV positive. And then that's all done at the level of the health facilities. And we proceed with other tests that goes with our routine activities, but also we do the RTI testing at the level of health facilities. And then when the result is a long term, we return the result to the patient. But when the result is recent, we send the sample for viral load testing at the level of the hub. And then when the result come, is where we return the result again to the health facilities. And then when we get the result at the level of the health facilities, we communicate the result to our client. So the second one is a non-POC facility. As I explained before, we at the non-POC site, we don't have the RTR test at the site. So what we do, addition to our routine activity, the level of health facilities, we took the sample, and then we send the sample to the hub for RTR testing. And when the sample is long term, we return directly the result to the health facilities. But when the result is a recent, we send the sample for viral testing for other procedure. And then after, when we got the result, we return the result at the health facilities level. Next. So here, this slide, I want to show you the sub activities that we are measuring for each step that have been mentioned in the previous slide. Where for the first column, you see this is the level, the POC, the site which is having the RTR at the level of the health facilities. We have the laboratory on site, and in laboratory you have some sub activity that we are doing there. First of all, when we got the sample for recent testing, we need to register the sample, and also we put RTI request in our viral SMS system, and then our samples are labeled, and then when we get the result, we enter the result of RTI in our lab register. And then after, we of course we don't enter the result only in the lab register, but also we enter also the result in the viral SMS system, and then we request for the viral load. So when we request the viral load, we transport the sample to the hub for viral load testing. So at that level, we have different we have different activities that we do there, including self-tubing, labeling, alcoting, and also worksheet creation, and also we are loading our samples, and then when we validate the result, we put the result in our Vilo SMS for everyone who have access to that system to get the result. So for the non-POC, there is a difference because on site we don't do the RTR at that level. What we only do, we do the registration, and then we request, we put the request in the file SMS, and then we collect the sample and the labeling the sample, and then transfer the sample to the district hospital or the hub. At that level, the process is the same as the POC. So for the control is done at the level of the health facilities. Only what we do in our routine activity is other test that goes with someone who is having HIV positive before he start the treatment. The other things we add is that we want to test the CD4 count at the level of district hospital. Next. So this to summarize what have been done during our assessment. Of course, we do trend we do plan to have our training and site activation that have been conducted back in September 2023. We had 13 data collectors, and we trained those data collectors. Among those data collectors included six the 6 data collectors, because we use the two different regions. 3 was in POC in Kigali, and 3 was in on POC in Eastern Province. We had also 4 staff that have been assigned to laboratories, and also we had 3 backup support staff. So data collection, conduct data collection between November 2023 up to January 2024, and in total we had 84 observation, including 10 recent, 70 long term, and 4 control. Next. So here we want to try to characterize our observation, our 84 observation. So we want to characterize them by type, and we have 3 different types. The first one is the region, and also the type of health facilities that we have been using, and also testing point type. So according to the region type, we had, like I said, we used 2 regions, Eastern Province and the Kigali City. But for the control, we try to have 2 control in Eastern and also 2 control in Kigali. So for the long term and recent, the most case come from Kigali, where in the long term we had around 47, and for the recent we have 7 over 10. So for the facility type, as I explained in our implementation, you have 2 facility type. We have the POC and non-POC, and for the control, we had 2 control in each facility type. But for the long term and the recent, most of case come from the POC site. So for entry point type is where we have all of our control come from the VCT, but as other type for long term and the recent, most of case it was coming from the VCT. Next. So this slide is trying to show the addition time when we try to compare our routine activity, the time we spend on our routine activity, and the time which is added when we are including also the recent activity. So normally we for our routine activity, it's 1 hour and a half, but there is a slight addition time when we are including also activity. But in summary, for the POC site, the time when we are doing also the recent activity, the time is ranging between 13 and 20 minutes, 13 for the long-term sample, and also 20 minutes for the recent samples. So the only time we can highlight here, the much time come from the time we spend when we are trying to return the result to the health facilities, as well as returning the result to our client. But if you try to see the range of addition time is between 13 minutes and 20 minutes. Next. So here is to share with you the three key take-home message that I can share with the attendees here. In Rwanda, the implementation of license testing is already integrated in our routine HTS services. So it means everyone who is testing positive, the recent testing is systematically. So the second one is about the model we are using. We are using the model of POC and non-POC, but the only difference that we have been the only difference that we have been seeing is that the only the difference is the activity that have been conducted at the level of POC site and non-POC site. In terms of the time, the additional time that is around the recent testing, there is a slight time that is additional to if you try to compare the POC non-POC site. So the time we add is not significant to consider. So also, as I explained before in the previous slide, the average time that we are adding on our routine activities is not more than 20 minutes. So you see, for our workload or at the time that we are adding on our routine activity is quite long. So I think this is my last slide. Over to you, Kyle.
Great. Thank you so much, Lenley and Dr. Bazio. So in summary, we found that on average, recency testing adds about 17 minutes to routine activities per each newly diagnosed patient in Rwanda and Eswatini. And as demonstrated by the graph here, you'll see, as you saw during the country presentations, Rwanda on the left and Eswatini on the right, the gray bars representing the baseline amount of time from the control observations for routine HIV testing services and case surveillance activities, and the green and blue bars stacked on top represent the individual recency-specific activities contributing to added time. So we'd like to mention a few limitations of the assessment. These timed recency testing observations are not representative samples, and the results may not be generalizable to other settings. Our inability to directly observe clients limited our ability to observe activities wherever the client was present. And 160 total observations included in the sample is relatively small. However, there are some noteworthy strengths. This was the first time motion assessment to quantify time spent on recent infection surveillance activities. And we were able to collect high quality data and do line by line real-time data review. Our data collection tool was designed to measure granular activities and allowed for qualitative data capture for additional context when direct observation wasn't always possible. And as we've mentioned, we successfully sampled a mix of point of care and non-point of care facilities in Rwanda and successfully represented all regions in Eswatini. So in conclusion, HIV-1 recent infection surveillance adds an average of 17 minutes to healthcare provider duties per each HIV positive patient when integrated into routine HIV testing services and case surveillance workflows. Recency testing and laboratory procedures did not add to the healthcare provider duties as they were often conducted in parallel with the routine procedures. And fully integrating recent infection surveillance into case surveillance and removing parallel activities like the recency-specific questionnaires could further reduce added time. So thank you so much, and we welcome your questions and comments.
Thank you, Kylie, Lemple, and Dr. Basil. This was really great. There was kind of an active live chat going on the side, and there are some questions for the speakers. The first is for Lemple. There's question about whether and maybe we can actually, Kylie, go to the graph, the overall graph, so we can anchor the discussion. Oh,
Yep, let me jump to it, sorry.
yeah, no worries. And this is the question is around the recency specific questionnaire that's being implemented. That adds time because it's kind of done in parallel with routine activities. Can you comment on whether there's any sort of consideration for maybe retiring that or using the routine system? Over.
Thank you so much, Suzue. Eswatini has already started some discussions since we highlighted earlier that recency surveillance is well integrated into routine. So discussions are around embedding the questionnaire into the pre and post-test information and counseling that is being given. Meaning when the clients are still there in the waiting room, that is when we'll be giving them the pre-test information, including recency information as well. Then now when you are doing a post-test, if a client is then positive, we'll then be continuing to the information that you introduced at the pre-test level. So there are some discussions that are around there, and we are looking forward to integrating and embedding the questionnaire so that we further reduce the time that is taken by a client in there. Thank you.
That's great. Yeah, because that really is the main contributor. So that I think that was like 10 minutes or more. So it will reduce the added time by more than half, I think. So that's interesting. The other question was for Dr. Basil around return of results. There's a question around, so return of results is highlighted in dark blue, I believe here, which adds quite a bit of time, as you noted. But you do that because of local guidelines, and maybe you can elaborate that. The question was about any evidence of social harm due to return of results, and maybe you can share the evaluation study results. Over.
Okay, thank you so much. Thank you for the questions. So in our country, maybe we have it in our guideline, so that when we are taking a sample from someone, is having the right to have the result, to know what is the outcome from the test that have been taken. So in our country, we when we do those kind of tests, we have to give the result to our clients. So the addition minute, it's around 13 minutes that we is added on our routine activity, because when you are returning the result, you have to take the time for counseling, and also for trying to explain what's happened, what is the reason, when they explain the result, and what will be the impact for other following days for the client. So about the IPV, we have conducted the study to know if there is any impact on our social life of our clients, and the results show that there is no impact. If there is a harm in the family, is not due to the result of the recent the recent testing that we have been done. So the difference is quite low. Maybe after the call, we can share the report, so that we can see that there is no impact on IPV. Over to you.
Thank you. And there is a manuscript that's going through clearance on that. So more to come on that. And the, I guess, lack of evidence of impact on IPV experience for those undergoing recent infection surveillance and receiving the result. There was another question. Oh, yes. The other question was around, and this is also for Rwanda, around the transportation piece. I know in Eswatini, the viral load that gets transported for recent samples are sort of integrated in the routine viral load sample transportation system. And in Rwanda, it's the same. But sometimes I know there's a parallel kind of transportation of recency samples to the lab in Rwanda. And I was curious to know why Rwanda decided that those samples are super important to send to the lab, even with, kind of parallel to the routine. Over.
Come again a little bit for the
Sorry. I know we didn't really focus on this during the presentation, so I wanted to add the transportation of RTRI recent sample to the laboratory. I know in Rwanda, sometimes you transport the recency sample separate from the routine viral load sample transportation, right? So I wanted you to comment on why RBC felt like that's needed, as opposed to waiting for the routine sample transport. Is that clear?
Yeah, is that clear? Of course, those samples are a little bit special, because of the importance of the result. It's a kind of surveillance first. That's why we give such importance to those samples, because we want to know. We can took them like those we are using for the viral for someone who is already on treatment, because we want to evaluate his viral level to continue the treatment. But for this one, it helps us to also to orient our interventions, our HIV program intervention, to see to make sure that we are getting the result as soon as possible, so that to know that there is maybe if we get the result which is RTR recent, to know that maybe there is an active transmission and we need a quick action. So that's why we took those samples very we give a very high level importance, so that it because to help us to know where we are, to know where there is active transmission, and also to quick intervene if it is necessary. So we can't sometimes our viral load on our routine activity, the viral load can take some much time. So if you are in active surveillance, it means when we are taking that much time to have those results, maybe it can compromise our intervention, or we can intervene late compared to and it can interfere with our interfere with our interventions. So that's I think I can try to explain on that. Over to you.
That's very interesting. Yes, I think to add, recency is part of active case surveillance, I believe, in Rwanda. So the results are being actively used to inform programming at a sort of aggregate level, and I think that is what therefore sort of the immediate action is needed, and also you return results, so you want to reduce the turnaround time. And there were a few more questions around return of results, so I just wanted to point to Eugenie's chat in the box that shows the report link, so you can all take a look at that. There's another question for Lenhle around, so it's interesting to see the sort of results here, both in Rwanda and Eswatini. The laboratory part doesn't add much time to routine activities, because I think the testing staff at the site or laboratory staff at the lab, they've really sort of integrated recency samples into sort of with regular samples, and they do parallel, they use the parallel, they conduct activities in parallel so that you don't add time. And I know there's some discussion around, maybe going for moving the HTS-based model to a laboratory-based model for recency. I don't know if you can comment more on that, Lenhle.
Thank you so much, Suzue.
Yes.
Yes. In country, we have already started the discussion of moving the recency testing to the lab, and I think that we are in full agreement with everyone, and that will also address most of the issues or the times that they are complaining about. But of course, like we have highlighted earlier, it is well integrated into routine. So the main contributing factor was the questionnaire. But of course, as we move further, we want to move to operationalize the lab-based model. Thank you.
And a follow-up question is, are you concerned about coverage of recency if you move from kind of an HTS model to a lab model? I know you have almost like, I think 95% coverage right now of positive samples that undergo recency. Are you concerned that might, moving it to the lab might reduce that? Over.
Of course not. If you look at the way the model will be operationalized, of course, sometimes we do have issues with the return of the viral load results in country, but I think that is one level that will be looking further and try to address all the other things that might be coming with it. Since this will be a new model that will be venturing in the country, I hope there'll be no other concerns that will be coming with it.
Thank you. Maybe I'll stay on that point and give this to Dr. Basil. We didn't get into the coverage piece for Rwanda. I know you implement both strategies, the point of care strategy as well as the non-point of care, so lab-based versus HCS. Are you able to comment on any difference in coverage? And I think in Rwanda, you're kind of going the opposite direction. You want to expand the HCS model. Although, yeah, maybe you can comment on your recent thinking around the model of implementation. Over.
Thank you. In terms of coverage, we have we have the site, the POC site in our Kigali city, and and we have a non-POC in the other provinces where we have from some site where we have high volume of client, where we have a high volume of new cases of HIV. And in terms of of expanding, we have been selecting different site with high volume of patient, where we want also to have POC site, because sometimes to remove that additional time that can come from the sample transportation. Maybe for the exact number, I can check and share with you the total number we have of POC site and non-POC site. Over to you.
Thank you. Another point raised by Sam and Eswatini is, and maybe this is for Lantley or Sam, is that Eswatini is perhaps moving to implement pre-treatment viral load, so baseline viral load for everybody. You implement that for recent samples as part of recency surveillance. Maybe you can comment on that and how recency will be integrated in that new implementation of baseline viral load.
And I have Sam to talk to that one.
Okay.
Thank you, Leslie. Thank you, Soswe. Good morning, good afternoon, everyone. Yes, I put something in the chat, Soswe, in trying to respond to your question in terms of saying, will the lab-based approach impact recency coverage?
Mm-hmm.
Yes, so we don't think so, because the country will soon be introducing the pre-treatment viral load for all PLHIV that are newly diagnosed. And the plan is the discussions around integrating the RTRI into the same sample that will be collected for pre-treatment VL, and have the RTRI being conducted in the lab where the VL processes will be conducted. So if the sample collection for pre-treatment VL for all newly diagnosed is efficiently done, 100% of them being collected, we anticipate everyone to have an RTRI conducted as well. Thanks, and over.
That's interesting. That will help, I can imagine. There's another question around sort of healthcare worker attitude for around recency recency surveillance, and this is for both countries. I guess it might be anecdotal, but what have you heard from the field in terms of implementing recency surveillance? I mean, your countries have really really done well in integrating recency, but it probably was a process. Maybe Lanley, you can start with, you know, how you went about integrating recency and how are the healthcare workers, both at the testing site and the laboratory, you know, implementing recency? Are there other issues? Is it really part of routine and it's no problem? Any sort of anecdotal or impressions you have from the healthcare workers? Over.
Thank you so much, Suzu. I think what I can share for Eswatini is that, yes, indeed, it has been a process when we started implementation. But one key factor that worked for Eswatini was the fact that we are not returning results to people, which then made the healthcare workers to be quite more comfortable because they were concerned about so many issues. So they really embraced and appreciated recency testing because it was sort of like a quality improvement tool that we were using. Because I will make an example. If you find a recent case, that is when you'll be making sure that you do not lose the key package that we need to give to a client, because sometimes there are those issues or gaps that are there at facility level. So they really embraced and used this kind of information to improve what is the package that is being given to a client. And it was really embraced very well. And we also appreciated the fact that it also improved quite a lot of programming using the data that came with it. And then while disseminating the data also to the facilities, to the healthcare workers, that is when then they embraced to see this is the kind of information they needed, especially in the epidemic that we have now in Eswatini, where now you are looking for those few cases. But this kind of information really helped us to be able to focus better, even using our resources wisely to get the cases that we need to get. So basically, it is well accepted and well routinized, and it's something that we think we shouldn't want to drop the ball and lose it. We really want to make sure that it continues so that it helps the people of Eswatini. Thank you.
Thank you, Langley. Dr. Bazu, can you comment on Rwanda?
Yeah. In our country also, there is no problem around it because now it has been integrated in our routine services that we are given to our client. And if you see on the minutes spent to do the research testing is around 3 minutes, and also the time we spend to return the result to our client also, even if it's a slight much time we spend, like 13 minutes, but it's a part of our post-testing counseling. So our healthcare providers have been trained and explained about the importance of those kind of new strategies. So as long as we have been integrated it in our routine services, so it's come easily for them to implement the research testing. And also what I can add is that we don't have too many cases that can also increase the work overload of our healthcare providers. Over to you.
Thank you so much. And finally, I wanted to highlight Bharat's comment on a recently published paper around Asante's performance as a diagnostic test. I didn't know about this paper, so thank you, Bharat. And I've allowed you to speak on it. Your microphone is active if you wish to comment on it. I think it's important for everybody to hear. Over.
Yeah, thank you, Suzu and ICAP team. I think great presentation. I know anytime you actually add recency testing or any other testing to the routine testing algorithm, it increases your time and also significantly cost, particularly cost also. So actually the paper that I have actually pointed out, the link is in the chat, was just recently published from group with Mike Bush, who is actually in San Francisco area in a blood bank. They actually have early seroconversion panel where individuals are, collected with a very, very close to the seroconversion time. And they use the test really to look at how well the test performs for diagnosing HIV infection. That was the focus of it, of the paper and the study. And what they found, actually, the test performs quite well compared to the other routine rapid diagnostic tests, which are also approved by regulatory agency, including FDA and WHO PQ. So we know that I think right now, Asanta is not approved by WHO PQ, mainly because it has a recency line and they are confused because recency is not really, they do not have a pathway for approving an incidence test. But if it was approved by either agency like WHO or FDA or even an in-country regulatory agency, the test can be included as part of the testing algorithm, as a second or third test, depending on what the algorithm is. It will reduce your time as well as cost. The issue, if it starts becoming actually part of the algorithm in the future at any time, of course, the volume of test use will go up and the cost will go down, partly because I think right now the cost is high, mainly because the test is used in a limited way, not as many as a diagnostic test would be used. So the manufacturing cost is significantly high to the company. And we are hoping in the future at some point, the cost goes down as well as, and this will also reduce the time, because there will not be any additional time of doing the testing. Just want to highlight that again, this was an independent study. We didn't even have anything to do with it. So, because I just want to point out that this test is working quite well, as well as it actually, works in our own hand. It's working in somebody else's hand quite well. Over. Any comments?
Super interesting. Thank you so much for the contribution. I hope everybody sees the link, and we will include that link as well as the evaluation study from Rwanda, the report link, as we circulate the recording of this of the webinar. I'm going to wait for 1 minute to see if there's any other comments or questions. Let me check the chat and Q&A. Yep. Well, thank you very much for joining, everybody. This was a great discussion. Look out for the recording and notes from the session. We look forward to hosting another webinar soon, so look out for the email announcement. Thank you very much for your time and have a good rest of the day. Thank you.
Thank you.
Bye now.